Yes, so I'd like to welcome everyone who's joining us this afternoon, this morning for Margarita, who's calling from the US, for the third of a series of 4 webinars looking at lessons that the English social care sector can learn from other countries, looking at the responses to the COVID-19 pandemic in other long-term care systems. And today we're looking at Japan, and we have with us Margarita Estevez-Abe from the University of Syracuse and Natasha Curry. And I'll be introducing the project and then hand over to them. So next slide, please. This project is funded by the National Institute of Health and Care Research. And the project aims are to draw lessons for policy and practice, as I said, from the international experience of COVID-19. We're also looking at scientific evidence to see how the English social care sector can recover from COVID-19 in the short term and can be better able to withstand future waves of COVID-19, similar shocks in the medium term, and become more resilient. Next slide, please. The way we're doing this is we gave some thought to how this process of learning could happen. And the first thing is to identify which are the lessons that we may need or that we could benefit from. And for that, we carried out a situational analysis of the English social care COVID experience. We also worked with our public involvement engagement group, and I see at least one member is here today. Hello, Wes. And we did a theory of change with people with lived experience and experts to understand what needed to happen for the social care system in England to get better. This helped us identify some priority areas and topics where we thought that we needed learning. And we did a mapping of scientific evidence and also of accounts of international experience. And this is available on a website called LTC COVID. From that, we went on to choose 4 countries where we felt that there were some relevant lessons to what we had identified as the key topics for England. And we developed these 4 case studies in Denmark, France, Japan, and the Netherlands. And we are now at the stages of bringing all this together. Today is an opportunity to think about some of the potential lessons from Japan to help us in the steps to develop some hopefully practical and useful recommendations that are relevant to the social care sector in England. Next slide, Natasha. We want to give a big caveat to all this work, which is that it's extremely difficult to compare how long-term care systems performed in the pandemic. And that's because it's already very difficult to compare how they do in normal times. We don't really have very good metrics or ways of comparing long-term care systems. They're very, very different from each other. And when it came to COVID, we had very few ways of comparing. And a potential one, of course, was the sadly very tragic amount of deaths that happened, particularly among the population that relies on care in different countries, and the population and the workers in the system, and as well as unpaid carers. But we can also think about what was the continuity quality of care for people who draw on care during the pandemic, and what have been the impacts on the well-being of people who draw on care and provide paid and unpaid care. Next slide, Natasha. And a very important thing to remark is that the different countries we'll be looking at have had very different experiences in terms of the depth of impact of the pandemic. So this is just looking at the number of deaths per 100,000 in the 4 countries that we're considering. And as you can see, Japan, who we're looking at today, has had a very different experience at community level in terms of the total numbers of deaths linked to COVID. And in fact, during the first year of the pandemic, the impacts were very, very limited, and they've had a higher impact later on compared to the UK and other European countries. Next slide, please, Natasha. And one thing that we need to stress is that when we look at the number of deaths of people living in care homes, that we found that there's a very strong correlation between the deaths of people in the community and the deaths of people in care homes. And this is telling us that there wasn't formula that allowed any country to completely separate the population in care homes from the rest of the population. The people who live in care homes are living in places where lots of people go in and out every day to provide care and to provide high proximity care, very, very intimate care. And that means that with the idea that you could ring fence care homes was not really a realistic option, and that we really needed to tackle COVID in full to be able to really protect care homes. And next slide, Natasha. If you want to continue.
Thank you very much, Adelina. Sorry, I don't know, these yellow lines have appeared on the screen. I'm not quite sure how, but hopefully they won't interrupt us too much. Yeah, thanks for that introduction, Adelina. So just a few words on the situational analysis that we undertook in England to give some context to the Japanese example that we're going to go into. So as Adelina said, we spent the last year or so talking to people who experienced the early wave of COVID in England, analysing documents, undertaking workshops to really understand what factors in the English social care system shaped the response and had an impact on how effective the response was. And through that, we were able to identify a number of priorities that we think need to be addressed in the future to make the system more resilient. And we've used these as a lens through which to look at the other countries. So I won't go through all of these, but I'll just mention a couple of the priorities that we identified. So there was a series of weaknesses, we thought, in the structure of the English system when it came to handling COVID. And one of those that came across very clearly when we were talking to people was around the accountability structures. And the English social care system is quite complex to navigate through accountabilities at different levels of government and shared between different local actors and national actors. And that lack of clarity became quite confusing in the early response to COVID and was an impediment to rolling out support for the system. One of the other things that came across very clearly in the research that we did was that a feeling that England missed a few opportunities for preparedness in the years before COVID, so that we weren't very prepared to tackle a crisis on this scale. There were a range of issues around what we've called people, which is about the understanding the diversity and complexity of the system, and then just the sheer number of people and the varying needs that they require. The response wasn't sufficiently tailored to that complexity and that diversity in the early months of the response. And we think there was a key issue around the workforce. So when COVID hit, we had high numbers of vacancies, high turnover, a very overstretched workforce already, in a not very resilient place from which to then tackle COVID. And one of the key structural features of the workforce that really impacted on the response was the fact that we have very high numbers of people on 0 hours contracts in England. And that had implications for isolation policy, because people don't get paid if they were isolating or they were sick, and that was a weakness in the response. And then finally, just to mention around resources, so the English social care system is often funded through sporadic injections of cash without a sort of sustainable source of revenue, and the decade before COVID hit was marked by austerity and budget cuts, which meant that there wasn't much opportunity for investment in the infrastructure. And so when it came to COVID and the need to isolate and manage people with infections in the care home sector, the estate wasn't very modernized and very well able to cope with that. So those are some of the sort of priority areas that we think really need to be strengthened if we are to create a more resilient system. And so we use these priorities to do a scoping study across the world to see which countries might have some relevant learning that we could translate to England, or they've had similar challenges that we could learn from as well. And we did a mapping exercise, and then we identified 4 countries where we thought there was some very strong potential for learning. And as Adelina says, that's France, the Netherlands, Denmark, and Japan. And we've had 2 webinars already on Denmark and the Netherlands, which are very interesting. And today we're going to be talking about Japan. And I'm really pleased that our colleague Margarita from Syracuse University is here. And she's been working with us to collect data and help us understand and interpret the situation in Japan. So for those of you not familiar with the Japanese system, I will give you a very whirlwind introduction to give you some context. So it's quite a comprehensive and generous long-term care system. It was introduced in the year 2000 for the over 65, so it's very much focused on the older population. And its introduction was driven by a concern over the rapidly aging population and the high levels of hospital use. And the high levels of hospital use, which were very expensive, were partly driven by the fact there was a very low supply of professional social care, long-term care, and what there was very high cost, so it's out of the reach of a lot of people. There's also an economic imperative, so there's not only an aging population but also a shrinking population in Japan, and the traditional sort of model of care was that families took care of elderly relatives. That meant that there were a large number of unpaid carers who were not able to join the labour market. So part of the driver for the introduction of the system was to free up those unpaid carers in order to enter the job market. So the system's funded through a mix of social insurance payments, which are levied on earnings of people over 40. Retired people continue to pay in. That's topped up by general taxation, and then user charges. So this is a system that's not free at the point of use, but it is capped. So there's no issue over catastrophic costs. The governance is quite clearly defined. So there are national frameworks around eligibility, user benefits, provider payments, for example, which give a kind of consistency and clarity at a national level. But local municipalities, so the local governments, have quite a lot of control over the shape of the system, and they contract with providers from various different sectors, private, voluntary, some state, not many, and they provide a range of care, from care homes to daycare to home care. What I think is quite distinct about Japan is just the high levels of daycare services that are used and provided, which makes it quite different from other countries. And the government has used policies and the way that they pay providers to try and incentivize non-residential care over the last 2 decades, and they've been fairly successful. So they've gone from, in the 90s, not a huge market of provision, to quite a vibrant, competitive market with a big emphasis on community and home care. In terms of workforce, familiar challenges to everywhere else that we've heard from, so high numbers of vacancies, shortages of care staff. I think Japan's slightly different to some other countries in that they have a generally high level of qualification and training, and they have a relatively low use of 0 hours style contracts, so unstable contracts. They do have some, but I think it's lower than in England. And then the other feature of the Japanese workforce, which I think is quite interesting, is the role of the care managers, who work with each individual who is eligible for care to help them navigate the system and choose their care package. So that was a very, very quick overview of the system. So what do we know about the impact of the pandemic on the system? Well, Japan's not awash with official data that's publicly available on infections and deaths, but we do have evidence to suggest that Japan successfully contained the first wave, at least. So it's quite a small percentage of COVID-related deaths occurred in long-term care compared to other countries. What we've seen since that first wave is a steady increase in mortality. But generally, when we look at Japan, we're looking at a country with overall quite low relative mortality. There was some impact on the delivery of long-term care services. Some daycare and community services closed, for example, but generally, when we look at Japan, we see a system that continued to deliver throughout the pandemic. Just a note on some wider context that's important to understand. So the response in Japan was very fast. So the government put out a national alert at the end of January about COVID. And then by the 1st of March, they were already talking about the lack of ventilation as a risk factor. So they're very fast in getting the public messaging out. And the public were largely receptive to that messaging, which focused on the 3 C's. So avoiding crowded space, close contact, and closed spaces, which is quite different to the speed of the messaging here and the kind of focus that we had on hand washing. The other contextual factor I think that is important to note is that mask wearing was already quite commonplace in Japan. So people generally wear masks when there's a flu outbreak or in allergy season, etc. So it was they relied on less of a behaviour change in the public around that. So through the lens of our kind of our England priorities, we've identified 5 areas where we think there is some potential for translatable learning from the system. And I think what's notable about the learning from Japan, which is slightly different from some of the other countries, is that all of the lessons are about what Japan had in place before COVID. So we're looking at a very resilient system. It's less about the response in the moment, but more about what they had in place beforehand. And I'm going to talk through each of these lessons and then bring Margarita in to kind of give us a bit more of a flavour from what she's been researching. So I think that the first lesson we wanted to just outline was on preparedness. So when we've looked at England, we've looked at various exercises over the years on flu preparedness mainly, and they've very much focused on health and not very much on social care. The exercises that did look at social care then weren't followed up by actions to address some of the issues identified. In Japan, there are robust infection protection and control measures that are embedded and established pre-COVID. So when the long-term care system was put in place, there was a requirement for all long-term care facilities to have protocols and committees for infection control. And they didn't just have the policies in place, they've actually used them regularly. And some of these protocols involve isolation and closures for care homes during flu outbreaks. So the idea of closing a care home was less sort of unusual and controversial there. The widespread use of face masks also was a factor. There's also a more recent legacy of managing TB outbreaks. And so that was baked into some of the infection control procedures, which turned out to be more suitable for flu than COVID because of the asymptomatic transmission. So how this worked during COVID, it meant that the long-term care facilities were able to step up infection control really rapidly. They didn't have to wait for new guidance or new instruction. The committees in each of the care homes were able to just put in place the infection control measures that they'd practiced and were familiar with. And at the time that COVID hit, there was many flu outbreaks and some care homes were already locked down because of flu. So some of those lockdowns were already in place and were just extended. So Margarita, I wanted to bring you in here and just get your reflections, because from an outsider's point of view, it looked like it was an incredibly seamless sort of switch into crisis management and infection control. Is that how it sort of how you would read the situation as well?
Well, yes, especially during the first wave, the second wave. You know, the system that they already had was, you know, extremely useful for containing, you know, COVID, and also they just managed to contain community-wide spread of the virus too. And really, there was no national lockdown. Well, although schools were just locked down in March, that just also overlapped with the spring break, anyways. So there wasn't the kind of the chaos that existed in the US or in England.
Mm-hmm. Yeah, I think that's really interesting. It does seem that they just seamlessly sort of clicked into place. I'll go on to the next one because there's a few points that kind of relate to the next lesson that sort of interlink. So the next sort of observation we had in England was that the complex accountability between the different actors in the English system made the response really quite difficult and slow, and it was confused. There was confusion about who was responsible for which. And I think the clarity of the Japanese system, with a very clear remit for the national government and then a clear framework and flexibility at the municipality level, meant that there was that clarity of who was doing what. And so those existing structures and governance worked effectively to coordinate the response, and there wasn't a need for additional task forces or additional governance structures. And I think we heard from the Dutch expert last week that the Netherlands, similar to England, tried to impose different sort of measures and different task forces to try and manage COVID. And I think what's struck me as particularly interesting about the Japanese system is the role of the local health bodies, the hokenjos, which seem to sit at, Margarita, correct me if I'm wrong, a kind of prefectural level, and are able to coordinate isolation, hospitalizations, and played a really key role in sort of, coordinating the response and support. Could you talk a bit more about Hokenjos and how they work in ordinary times and how they worked in COVID?
So in the ordinary times, just Hokenjos, they're in charge of monitoring contagious diseases, and they're also in charge of vaccinations. Although during the COVID, they just took on the extra burden because COVID was designated by the government as an extremely contagious disease. So once it was designated as an extremely contagious disease, anyone who had symptoms had to just contact the Hokenjo. Hokenjo had to arrange a PCR test. And if one was found to be positive, Hokenjo then would arrange for hospitalization. So this just got too much towards the end, because once the number of positive cases increased in the community, not everyone could be hospitalized. But we are just talking about the LTC system. So in the case of the LTC system, so if you suspect that someone just got infected, as an LTC administrator, all you had to do was to call the local Hokenjo. And they would arrange for the testing and what to do. You see, so in a sense, they just knew whom to call.
Yeah. Whereas here we had to set up a whole new sort of test and trace system that kind of was in parallel to the existing public health structures that we already had.
Yeah, so Hokenjos took care of contact tracing. So they did all of that. So in that sense, who did what was very clear. When it became very apparent that Hokenjo was doing too much, then prefectures did have to just set up other systems. And what they did was many of the citizens who were worried about about the disease just started just calling up Hokenjo, because that's the point of contact. So many people just started just calling them with their worries. So prefectures had to just set up a different call center, which concerned citizens could call with their worries.
Okay.
As a way of reducing the burden on Hokenjo. So some changes were introduced later on, but when the pandemic hit first, so there was already a clear structure in terms of who did what.
I think that's really interesting. So there became a capacity issue, but that clarity of roles, I think, is a really interesting learning point for us. One of the really controversial issues here was in the discharge of people from hospital into care homes who hadn't been tested or were COVID positive.
No, that was just never, this discharge was never an issue. So the issue really was more about what to do when there were infected sort of residents in nursing homes, how to transfer them into hospitals fast. So discharge wasn't really an issue.
Okay, and is that just because of the numbers that we're talking about?
Well, it's the numbers. Well, the numbers went up, in the 7th and the 8th. So the numbers only started to go up with Omicron and the latest sort of variant of Omicron. But even then, it's because the latest variants are not, they don't cause very severe symptoms. So younger people who are just getting it do not really require hospitalization. So even in the latest waves, there hasn't really been an issue of how to discharge
okay.
in a patient.
That's really interesting. I think, am I right in thinking that they also had designated hospitals for COVID positive people?
Yes.
And was that a system that had already been sort of established before COVID? Was that a sort of practice protocol?
So this is so the government designates. So when there is a contagious diseases, they will be ranked, and COVID-19 got ranked very high. So once that happens, only certain numbers of hospitals would be just taking in the patients. Which means that the rest of the hospitals could just carry out their business as usual. So people could have knee surgeries. They could have heart surgeries. So there hasn't been this thing, the situation where all the hospitals got overwhelmed by COVID patients.
Mhm.
Routine procedures or cancer operations being just postponed. Something like that didn't happen.
So it's largely business as usual then for the health system at least.
Hospitals, yeah.
Yeah, that's really interesting. Thank you. So the next sort of lesson that we've identified that we thought was quite striking about the Japanese system is about the established communication channels. And I suppose it links quite clearly to the accountability structures that we've just talked about. So there are already established communication channels between the national government to providers and local governments. And I think that's in contrast to what we saw in England, where we didn't have an easy way for national government to communicate with individual providers. There were different pockets of information about contacts spread across the system, but no easy established mechanisms. I think we've kind of created those as we've gone along, but what we note in Japan is that they were already there and working. So from the top down and then the bottom up requests from providers. But the fact of the observation that we made in Japan that's really interesting to us, I think, is the role of trade associations to which all the providers need to be members. Margarita, I thought, could you just explain a bit more about the role of trade associations and their status in the system?
Yes, it's not that all providers need to be members of trade associations. These trade associations are not compulsory, but most do. Trade associations are just, they basically have dual role. So they are intermediaries between the government authorities and their members. So trade associations are just watching out for any of the new information, legal changes that are just coming out of the government, and they just compile them together and provide that information to their members. Mm-hmm. So members have an incentive to join these trade associations to keep up with legal changes. Now, in all the LTC providers in Japan, for most of they rely on the reimbursements from the government. So they do have to watch out for any legal changes, regulatory changes that are in place, or any discussions for legal changes and regulatory changes. They want to, they want to be informed. So lots of members do join trade associations because they do get very important information from trade associations. But trade associations also collect information from the members and pass it on to the government authorities to say, after the first pandemic, some of the care providers just ran into economic problems. So this wasn't really for nursing homes. But in the Japanese case, many families just relied on daycare centers for frail elderly. Many people rely on home care services. Many families, afraid of COVID contagion, stopped if they cut down on using these services. So what happened was providers of daycare services, providers of home care services, they encountered economic difficulties. Mm-hmm. So trade associations of those providers almost immediately just carried out surveys of their members. Mm-hmm. And they would just pass that information on to the appropriate government ministry and the bureaus.
And are they the lines of communication between those trade associations and the government bureaus, is that a sort of established regular relationship? Yes.
And this is not only for LTC. I mean, this happens for almost every product market sector in Japan. Mm-hmm.
Yeah, so I think we have something similar here in our membership umbrella bodies, but I think what was maybe distinct here is that communication between those membership bodies and the government were not a sort of regular and established relationship. And am I right in thinking that trade associations are sort of legally recognized, so they have an official sort of status in the system?
So that depends on it depends on the trade association.
Okay. Okay, thanks. That's really interesting. So the next sort of lesson that we thought was quite interesting was around the shape of the Japanese long-term care workforce, and how certain features seem to help with managing the response to COVID. So Japan has a highly educated workforce. It's one of the most highly qualified workforces in the world, and staff are encouraged to train and gain care qualifications. There are also strict staffing ratios in place across the system, and they do use some sort of insecure sort of 0-hour style contracts, but they seem to be less widespread than they are in England. Japan still suffers from severe shortages of long-term care staff, just as we do, and there are the familiar challenges of low pay and low perceived value of care work. Over the years, they've tried to recruit from abroad, put quite a lot of effort into bringing people in from abroad, but that policy is not really delivered at scale. So the impact during COVID, I mean, I think like all countries, because of the staff shortages, the workforce was possibly the biggest challenge. But what we've heard is that the high levels of training and high levels of qualification actually facilitated the implementation of new infection control measures. And we think that the low proportion of workers on unstable contracts limited the impact of isolation and sickness that came along with COVID. The government did put in place some additional support measures for some staff, so like a hardship bonus, for example, but that was limited to affected care homes. So only the care homes that have been affected by COVID. And similarly, some funding was allocated to counselling for staff who had been working in affected care homes. So there have been limited support measures around specifically for staff. Now, I think one of the interesting points I wanted to pick up with you, Margarita, was around the role of the Hokenjos here in the staff redeployment. So in trying to identify where there were outbreaks of COVID and where the staffing ratios were out of step. But I think there was still a struggle to recruit more personnel to manage the COVID outbreaks. Margarita, could you just reflect on how the Hokenjos played a role in this staff redeployment?
So that's not Hokenjo. So Hokenjo didn't have anything to do with the staff redeployment. So that was done by the prefectural government. So this was just something, so this was just something that was done for the pandemic, because it just became just quite apparent that the problem was, what do you do when the staff get infected? Because when there is a cluster infection, it's not just residents, but the staff who get infected. So all prefectural governments were tasked on creating this redeployment scheme.
And so that meant that because they had the overview of where those infections were and they had that data, they were just able to send staff. I mean, how does that work?
No, so it's by request.
Okay.
And there are just clear guidelines on how that happens. And also the prefecture would help with the cost of redeployment, because the nursing home that has been affected, they will have to shoulder the extra burden, extra cost of hiring more people to cope with the phase of infection. So prefecture was the one who was covering.
So I think that sort of regional level of governance, I think there was quite important. We don't really have that in England. We have the national and then we have the local, but I think there's something in that Japanese system of that middle tier that played quite an interesting, important role.
So what Hokenjo would do is with the dispatching of the medical team. So there would be a medical team that would visit affected nursing homes, help with the containment of infection, and also when there was a massive wave, once the numbers went up, there was situations where it was difficult to transfer infected patients, infected residents into hospitals. So then the special medical team would be dispatched to basically take care of the infected residents at the facility. De facto just turning part of the nursing homes into a kind of a medical unit.
Yeah. That's a really interesting point, actually, Margarita, which I think will be interesting to people here, because I think what we observed in England is that people who were in care homes with COVID struggled to get healthcare. They've struggled to get the healthcare into homes, or they struggled to get sick people into hospital. But it sounds like the Japanese system enabled healthcare to continue to be provided throughout, whether COVID positive or not. Is that fair to say?
Yes, so yes, and I think this is just probably because Japan is more natural disaster prone, and there is a special sort of medical unit. Again, I think it's physicians and nurses who just volunteer to be part of this unit. So this is disaster medical assistance team, and so they would be deployed.
That's really interesting. So yeah, that history of disaster there kind of helped with the prep for that. I've mislabeled that. That's should have been lesson 4. So lesson 5, our final lesson from Japan, was around the money. And as I said before, the English system has been characterized by a funding system that injects sporadic injections of money into it to keep it going, but there's no stable, sustained source of revenue that gives the system certainty over time. The Japanese system, because it's funded via taxation and social insurance, means there is a stable source of revenue coming into the system. And the way that the system operates is that the national government sets provider fees every 2 years. They're reviewed every 2 years, and providers have certainty over those 2 years of what they're going to be paid for what they deliver. So I think that certainty has given the provider market quite a lot of stability. It also has enabled investment into infrastructure. So I think at the point that COVID hit, the provider market wasn't suffering from the instability that the English market was, and facilities of care homes have largely been modernized over time. And the payment schedule that was already established meant that there was an easy way for central government to get funding to the front line. In England, that didn't exist. It now does. They had to put in pass new legislation in the Health and Care Bill to enable direct provider payments. So during COVID, I think that the provider market held up fairly well because of that stability and because of the investment pre-COVID. Because of the mechanisms, the government was able to quickly distribute emergency support. And also, I think the fee schedule enabled some flexibility in provision. So Margarita, you just mentioned that lots of people stopped using daycare services because they were worried about infection. And to support those providers, the government was able just to help them switch from providing daycare or community care to home care. What's been the sort of sustained impact on providers throughout? Are they still in quite a stable position, or are they reliant on sort of emergency funding to get through them?
So it's back to normal. So in 2020, just lots of providers have gone bankrupt, but the numbers just stabilized as of 2021. So 2020, just some did exit the market. And this was just something that just worried the national government as well. So all the government authorities were very worried about the number of providers being reduced as the effect of the pandemic. But it just, the situation just improved, and now it's just back to normal.
That's really interesting.
It hasn't really been long-lasting effect of this.
And has the balance of kind of provision gone back to how it was? So have daycare centres reopened that shut, or has there been more of a permanent switch to more home-based care?
No, now the daycare centers are back. So now the discussion is to allow nursing homes, just more, basically now the movement is to allow LTC providers to operate multiple types of services.
to diversify was that not allowed before then, or
no? So not exactly. So some nursing homes did also operate as daycare centers, but as legal entities, they were separate.
right?
So now the change that the government is considering is allowing daycare centers to provide home services.
Mm-hmm.
And some of the daycare centers also have specialized in providing physical therapy. So the idea is to allow these daycare centers to monitor their patients at home too, by going into the homes and just continuing with the same menu that they provide at the daycare center.
Oh,
So there are some sort of innovations that the government is considering. But I think this also just comes from the experience of daycare centers having been hit very hard during the pandemic.
Mm-hmm. Okay, thank you. That's the end of our presentation. I don't know if our audience have any questions that they'd like to put to me and Margarita.
I see a first question from Jay Wilson.
Yeah, hi. Sorry, so this is a general question. Just the economics of Japan. I don't know how they managed to. I mean, he talks about hospital capacity. It's just unheard of in England. What you described about having hospitals that can take potentially contagious people, and the whole system still carrying on. I just wondered how's it all? Where's the money come from? Considering you've got an aging population, and quite, like you said, I think right at the start, quite a small workforce compared to that the elderly population.
Margarita, do you want to have a go at that one?
Yes. Well, not everyone got hospitalized. By the law, everyone who proved to be COVID positive had to be hospitalized. Many couldn't. Obviously, nursing home sort of residents were priority. Just many people just ended up staying in hospitals, but the government would just provide meals and everything for these people. So that was just a lot of money. So how could Japan do this? Well, they managed, but the Japanese government is highly in debt. So the Japanese government is just borrowing from its own society to cover the cost. So, is this just sustainable? Is this not? Japan is just one of the most indebted government. So there is a big concern for the sustainability of this system. Just given the level of demographic aging, almost 1 in 10 is above the age of 80. So this is something that we haven't witnessed before. So it's difficult. This time it has worked. But the government does realize that they really just do not have more money. So they really do want to increase the out-of-pocket cost. But the elections are coming up, and they don't want to talk about things like this when there's an election. And in Japan, the elections are very frequent, which means that this just gets postponed.
Okay.
And if I may add, I think there's another factor, which is that the experience of the pandemic was very different in Japan because there was very successful community containment, especially on the first year. So it was much easier to maintain the functioning of the overall health system, because although people were hospitalized, there were not as many people infected as we saw in other countries.
Yeah, I think one of the other factors is that Japan has a big hospital bed base compared to us. I don't have the figures to hand, but it has a lot of bed capacity, which probably meant it had some spare capacity in the way that we just didn't have.
Well, this is there were beds, but the staffing capacity was much smaller than the bed capacity. So what we have learned during this pandemic was that it's the staffing capacity of the number of beds
I think
But
that's what we all learned.
yeah, but it's true that the level of the Japanese nursing home sort of employees, during the first sort of phase of the pandemic, they would even refrain from eating in restaurants or just going out to see friends. So the nursing homes really emphasize the importance of staff avoiding any situations where they might be infected. So that worked initially, but we know that as the pandemic continued and once people got vaccinated, people did start to resume their normal lives. And so now the nursing home staff, they would go out and see friends. It's just not like at the beginning, but at the beginning, the kind of the level of understanding and the commitment of the nursing care staff was extraordinary. That the fact that they would even refrain from seeing friends.
Sorry, just a quick follow-on question, because I just wanted to clarify what you said earlier. Did you say that the schools only shut for 1 month in March? Is that right? Or was that they shut in March?
Slightly longer. I think it just also just depended on the place, and just weirdly, the university probably just continued being closed longest.
Okay. Thank you.
I see we have a question from Margarita Angur, who's a member of our public involvement engagement group. Hello, Margaret.
Hello. I happen to have a Japanese daughter-in-law, and I was actually in Japan last November. I was very impressed by the number of this is just sort of extra before my question. I was very impressed by the infection control at every railway station and hotel and goodness knows what. There were thermometers that you had to pass through to, if you have a raised temperature in public, it was really indicative you might have COVID. And I, in fact, developed COVID whilst I was in Japan, unfortunately. But that's not my question really is about the finance, because I know how different it is in Japan, and to me, rather complex. My daughter-in-law says that the family, you have to pay a 30% contribution in her family's case. And therefore, obviously, the whole financial situation is very different to the UK. You may have insurance, but for example, my daughter-in-law's father died of pancreatic cancer, which he'd had for several years during COVID and of course before. But towards the end of his life, he had to go into long-term terminal care because although her mother was asked to look after him at home, as Japanese families are asked to do formally, she had really been approached to have him when he was really very poorly. And the Japanese system expected her to take him home and nurse him at home. And because of her own health conditions, she was unable to do that. But what transpired was, towards the end of his life, he went into long-term care, but it was a very, very significant cost to the family. It certainly wasn't all covered by insurance. So, I mean, my own family, we were self-funders when my mother and my husband had dementia. But I'm just saying it's difficult to compare the health systems, I would say, and the financing. But I mean, in lots of ways, I must say I admire the Japanese organization generally in coping with COVID, i.e., we delayed our trip because we couldn't get into the country for 2 years. Japanese were allowed in slightly earlier, but, so there were general restrictions and it was so obvious, and the general Japanese population are very aware of cross-infection, and wearing a mask is pretty general, as Margarita knows well. So it's just a very different environment and a very different financial system. But of course, we can learn the lessons of their good practice. It was a health tour, actually. So I visited several hospitals and rural facility during my trip.
Margarita, would you like
Yeah.
to
Yes,
comment?
so palliative care. So nursing homes do not provide palliative care. So that must have been a hospice, which counts as sort of medical facility. So that's covered by the National Healthcare Insurance and not LTC. So these who pays for what is just very clearly divided. And one thing that happens, and this is true for medical facilities as well as nursing homes, patients have to pay for the insurance only covers the service, doesn't cover food, doesn't cover the bed or the room. So obviously, so when you when you use a medical facility for medical procedure or palliative care, if you want to be in a single room, that would be more expensive. So the fact that the family just paid for 30%, so that must have been the cost of the room that the family chose for the father.
My understanding, Margarita, is that while you pay, if you're in a care home, so long-term care, you do pay room and board, and then you pay usually 20%, sometimes up to 30% of the cost, depending on your income. But your contribution is capped at a certain maximum. So you do. So while you do make a contribution, it's not on the scale of the kind of catastrophic unlimited costs that we face here at the moment.
No, and for instance, my father just chose to do so my father's Spanish, but he passed away in Tokyo. And we managed to provide in-home palliative care. And again, we just had a care manager and a medical care manager. And so they just took care of everything. So we never had to just learn about the details. It was just so easy, and it was incredibly cheap.
That's interesting. I think it's all relative, and I think that role of that kind of care manager, navigator, is a really, really key one that we could learn from.
Yeah, because it really reduces the stress on the family, and they're experts on how the system works, and they know each other. So the medical care coordinator just knows care managers, and they know providers. So it's incredibly seamless. So you just say that you need a wheelchair, and they will deliver one that day.
So the sort of fragmented sort of experience that people have here in normal times and in COVID between the health and care system, is that just not an issue in Japan then? If you have health and care needs, is that just seamlessly sort of coordinated on your behalf?
If you qualify, so if you qualify for the LTC insurance, so if you're covered in the LTC insurance, and if you qualify, then you will have a care manager, and then all sorts of sort of help would just kick in. There's medical care managers. So because of the demographic aging, the government has been just trying to cut down on the medical cost. So they really do want patients to stay home as long as possible. So they have been just investing in creating this sort of community-based healthcare service. So palliative care is one. Sort of chronic diseases. All the citizens tend to have chronic diseases, so the government is just doing their best to keep these people just live in their homes as long as they can. And so once you just get a medical care coordinator, and so these people will just help patients' families manage, navigate the system.
That's really interesting. We've just got a few minutes left. I don't know, Adelina, if you want to ask any other questions, or I just have one sort of last forward look question.
No, I was thinking from the perspective of the English system, how one thing that maybe now you mentioned the care managers and how important their role, I think, if I understood correctly, is as well when people are admitted to hospital, because the same care manager will be that they had before will also be in charge of helping them with the discharge process. And I think that's something that is very topical at the moment in England, what happens with trying to help people with discharge from hospital. And I think that's an important piece of the puzzle, potentially.
Yeah.
So that's just more of a comment from me.
Okay.
But I just wanted to thank you, Margarita. And I don't know if there's anything else that you can think of that you'd like to share with us.
Can I ask one sort of
experience?
last question? Just Margarita, what do you think? Has Japan learnt anything, and what do you think is it going to change anything now as a result of its COVID experience?
So that would be just allowing daycare centers to also provide home care services. So that's just clearly one thing. But other than that, not really. That I think the national government, the politicians are not really just paying that much attention because nursing homes just seem to fare quite well just compared to other countries. And the concern really is the cost and the labor shortage.
So money and people. Okay. Thank you.
A problem shared. Yeah, so I think then it just leaves us to thank you, Margarita, particularly, and Natasha. And we have another webinar on the 10th of March. That one will be led by Camille on with Alice, I can't pronounce her name, but with a consultant from France. And we will be looking at the French experience, which is, of course, very different than Japan. And we will be sharing thank you for putting it in the chat, Camille. We will be sharing this recording and also the previous two on the Netherlands and Denmark, in case you want to look a bit more at the findings. So thank you very much. And hope to see many of you on the 10th.